Hello, everybody, and welcome to the Florida HIE Services virtual panel discussion on the Encounter Notification Service, or ENS. This is actually a virtual panel on what ACOs can teach us about reducing hospital readmissions from the information that they receive from this service. I want to thank you all for joining us and learning from these panelists, these ACO panelists that are using information to help them engage patients and reduce unnecessary hospital admissions and readmissions. My name is Pamela King. I am the Health IT Outreach Coordinator for the Agency for Healthcare Administration. I'm just going to go over a couple of housekeeping items before I turn over the discussion to our moderator. We will have a question and answer period at the end of our panel discussion today. So if you have questions, you can type them into the question section of the webinar toolbar, or when we get to that question and answer period, you can click on the raise hand indicator in that toolbar, and I will know to unmute you. You will be muted until we get to that portion of the webinar, and will be unmuted as you raise your hand. Or if we have additional questions regarding or need clarification regarding the question you typed into the toolbar. This presentation is being recorded, and we will provide you with a link to the recording within the next few days after the presentation. So you will have a copy of the presentation that you can share with your colleagues if you would like. So now, without any further ado, I would like to introduce today's guest. We have Evan Carter. Evan, and he will be our moderator today. Evan is the Senior Director at Audacious Inquiry with over 12 years of experience in the health IT field. He's been involved in the Florida HIE since its inception in 2011 and served in a wide range of capacities, from Deputy Project Manager to Outreach Coordinator to currently being the Program Director on behalf of the Florida HIE's vendor Audacious Inquiry. We also have as panelists today Dina Lewis. Dina has over 20 years of healthcare experience with a strong focus on IT systems and financial analysis. The healthcare sectors where she has performed in hospitals, managed care contracting, skilled nursing facilities, and accountable care organizations. So her knowledge and breadth is very wide. She is currently employed at Primary Partners and overseeing the analytics department, and has been able to achieve $2 million in shared savings in Medicare and commercial payer contracts. We also have Dr. Rebecca Prostko. She is an internist in Palm City, Florida, and received her medical degree from the University of North Dakota School of Medicine and Health Sciences. She did her residency at the University of Florida Shands and has been practicing for more than 20 years. She is a member of the physician-led Palm Beach ACO. Both of these organizations represented by our panelists are longtime users of Florida's HIE services. Primary Partner was the first ACO to sign up with the state HIE in May 2015, and Palm Beach ACO began its participation very soon after that. So both longtime users and have a lot of knowledge about what they have, can share a lot of information with us on how to use that data. So Evan, I am turning it over to you now.
All right, thank you very much, Pam. First and foremost, thank you, Dina. Thank you, Dr. Prostko, and thank you, everybody, for joining us this morning. I hope and feel confident this is going to be a illuminating discussion. Before we jump into the Q&A, I just wanted to kind of give a quick overview of the encounter notification service that's, the underlying technology that we're here to discuss today. For those of you, if you're not aware, just to kind of contextualize everything, our encounter notification service is, as its name would indicate, a service through which you receive notifications on your patient's encounters. It's a pretty straightforward name. The idea is that the Florida HIE has established connectivity with well over 250 data sources at this point in time. And when I say data sources, we originally started with acute care hospitals, of which we have over 95% of all licensed acute care beds in the state, giving us real-time data on admits, transfers, and discharges. If I were to say it in the right order, it'd be admits, discharges, and transfers, which are otherwise known as ADT messages. It's real-time data. Says, Evan Carter was just admitted at this hospital. This was the primary complaint. This was the time, attending physician, things of that nature. And that's what this service is powered by, are those ADT messages. We're not talking about lab results. We're not talking about discharge summaries or CCDs or any other, for lack of a better term, more complicated data pieces. It's really lightweight encounter data that we're working with today. And as I said, we originally got 215, 220 hospitals connected as data sources. We've since expanded into the rehab space and have about 80% of the rehab beds in the state, inpatient rehab beds, covered as data sources as well. And very noteworthy, we just brought our first skilled nursing chain live as a data source just in the past week or two, and have over 100 additional skilled nursing facilities in the queue in our onboarding pipeline to come on as data sources within the next month or two. So we're really hard at work to make the universe of data sources from which you can receive encounter information as broad and robust as possible. So what we do once we get that connectivity is we engage folks like Primary Partners in Palm Beach ACO and a number of other organizations throughout the state as subscribers. And what they do is they send us a list of their affiliated patients that they'd like to subscribe to, and they simply send us a spreadsheet of the patients and their demographics. We load that into the system, and what we do then in real time is compare the demographics that the subscribers, the patient demographics that the subscribers have given us, to all thousands and thousands of ADT messages, encounter data that we were receiving from our data sources in real time. And in each one of those, we look at the patient demographics in the encounter messages and compare them to all our subscribed patients, of which we have, I believe, over 9 million at this point, Floridians in the system. And if we determine that there is a match, that the Evan Carter that just presented at the hospital is the same Evan Carter in the Palm Beach ACO panel, an alert is generated and sent to the subscriber, highly configurable in the format and frequency that they want. We can integrate with pop health platforms or EMR vendors, whatever the case may be. So we've got a number of means, a number of different types of endpoints that we can route it to. We route it to downstream providers, which is something I have a feeling we might be getting into later on in the call. But that's from a technical standpoint, that's the service. We're taking encounter data from providers, we're comparing it to lists of patients from our subscribers, and if we determine a match, we then route that information to the subscriber to let them know that their patients are having an encounter up to near real time, a matter of seconds or minutes after the actual encounter has been entered. So with that, we can certainly field questions later or offline as to the details as to how the service works. But what's really impressive to me, and I think of significant value, is how these folks are using the data to really affect meaningful improvement in patient outcomes and cost savings. So that is of course really what we're ready to drill into today. So with that, I'm just going to go ahead and jump in some questions. Dina, Dr. Prostko, if you're ready, if that's all right. So
Sounds
just
good.
just to start off, I know Pam gave some pretty good introductions, but could both of you just give another minute or two on your respective ACOs? How big your patient population is, how many affiliated physicians you have, et cetera, just things of that nature.
Absolutely. This is I'm Dr. Rebecca Prostko. Can you hear me?
Yes.
Okay. With Palm Beach ACO, I was a founding member of the ACO back in 2012, and we've grown quite remarkably to a beneficiary population of around 70,000 Medicare lives, and we have something around 400 doctors, both primary and specialists. And we've been quite successful with shared savings, and we've been a large portion of that, or a good portion of that, has been our participation in this program. We have a PBACO app, which we all have on our phones and desktops, and our staff has it on the desktop as well. When we get notifications of any encounter, whether it be ER, discharge, admission, we contact the patient almost immediately. And many times, if we get an ER notification, the doctor can call immediately the ER and find out what's going on, avoid an admission, or get the hospitalist down there as soon as possible. So it's really been quite helpful with regards to our management of patients. We don't lose track of them, and no one's lost to follow-up, so to speak, when we do get this information. Now we are certainly able to contact and discuss with the patient, and then one of our goals, of course, is to get the patient, regardless of what admission or discharge, into the office within 7 days, so that we can see them, reconcile medications, make sure they've got the support services they need, and follow them up in very short order, so that we can avoid readmissions. So this has been a very helpful program for us in many ways.
Excellent. Thank you very much. Dina, how about primary partners?
Yes, hi everybody. So we're an integrated group of independently owned physicians, physician-led and owned. We have collaboration or shared savings agreements across Medicare and several of the commercial payers. We have about 200 physicians that are mostly comprised of family practice and pediatrics. I think together throughout all of our contracts, we have approximately 50,000 lives, and we've brought into the group about $30 million worth of shared savings. We've been on the ENS notification since 2015, and we find it extremely helpful.
Excellent, thank you. So I want to, really kind of hone in on precisely the process between, the process that flows between receipt of the notification to patient outreach, to subsequent office visit, and any other steps subsequent to that, in terms of, unnecessary utilization avoidance, so to speak. Dr. Prostko, to kind of start with you, you mentioned that you have an app that basically, kind of extends the endpoint. Normally our base offering, again, for those that may be less familiar with ENS, we'll send the notifications to an SFTP site or to a direct messaging account, or some other database hosted by a subscriber. It can be very rudimentary, but it can also be very sophisticated. It all depends on the best fit. But so you all are receiving those notifications and then forwarding them downstream to an app, as you mentioned, that all of your participating providers have. Can you kind of go through the process in a little more detail as to how you then receive the notification in the app, and then who contacts the patient, and what does that initial conversation look like?
Yes, I can. Okay, we get, it's remarkable in that we get it's almost immediate notification. And often if we get a notification of a discharge, the patient hasn't even left the hospital yet. So these notifications are really coming in a very timely fashion. Also, we get an almost immediate notification when the patient arrives in the emergency department. We do have the physician can set their phone so that they get a sound, a ding or the beep or whatever, whenever one of these notifications comes through. And then there's also times when you can silence that, so that it doesn't bother you at night or whatnot. And then it also pops up on my desktop and also on my two front office girls' desktop. So when an ER person comes in, I see it almost immediately, and I can find out what's going on, call the ER, discuss it with them, look up the hospital record, follow whatever's happening, and then the girls will call the patient and schedule the patient to come in within the next few days so that they have appropriate follow-up. Same thing with discharges and admissions. Admissions or transfers even to another hospital. The admissions, of course, we may contact the patient or just follow it, follow the admission through. But on discharges, we do contact the patient immediately. Sometimes it's myself or the nurse practitioner or the office staff to discuss what happened. We get all of their records out from the hospital into our electronic medical record, and then we arrange for the patient to come in sometime in the next 5 to 7 days. So it's been, and then we are able to cross them off on our app to see that yes, indeed, we did do that. And of course, we have a scoring situation where the ACO comes back at us and says, well, your score for app use for, and they do divide it up according to physician or to office staff or to whatever. So we can see where our performance is with regards to use of the app. It's a pretty rare patient that isn't in the system. It does happen on rare occasion, but by and large, it's really, really pretty complete and very timely. And we are able to make sure we keep good close contact with that patient to prevent readmissions or prevent complications.
That's excellent. I have a ton of follow-up questions, but I'm going to go to Dina first, just to get the comparable baseline from your side, Dina. Can you kind of walk us through that same process from in detail, notification receipt to patient outreach and subsequent follow-up?
That'd be great. We definitely slightly differ from Palm Beach ACO. We do not have an app. So we are operating after the fact. In some of our hospital systems, they do have an application called Perfect Serve where they deliver the real-time notifications, similar to what Dr. Prostko was talking about. But for the most part, we are operating after the fact, whether they went to the ER or to the inpatient admission. So our process is internally we get 2 files per day from ENS that says who was either admitted or discharged to the ER and inpatient. And then what we do is every morning we combine all of our reporting mechanisms for ADTs into one report, and then we shoot it over to the physician's offices. The offices themselves prefer to make the phone calls to their patients and to schedule them in for a follow-up appointment. Our role at the ACO is to deliver those notifications and then obviously provide best practices and training and even call scripting to the practices and able to move the mark and to reduce the frequency of ERs or readmissions.
That's excellent. Thank you. Going back up, Dr. Prostko, to you for a second, and kind of historically, I'm really interested in what you said specifically with regards to you contacting the hospital on admit, and historically, we thought we thought notifications when we designed this service, we thought notifications would be going directly to PCPs and other providers, and that they would be doing just what you said. But a lot of them don't. We see a lot more utilization with regard to the front office staff, the schedulers, in terms of reaching out to do the post-discharge coordination and follow-up visit. So you're a practicing physician. You are a very busy person. I'm curious as to, a little bit more like how you fit that part, the hospital outreach on admit, like into your workflow. How many do you only contact, for a subset of your patient encounters when you see them? Is there some way that you triage that? How do you fit that into the workflow of a practicing physician?
Okay, for myself, I don't contact every single admission or every single ER. Okay, so if they happen to go to the ER for something, I see that they're discharged from the ER, I make sure the office staff calls, and the office staff make sure they get the patient in within the next several days. If there's, let's say, someone who's going in there with an initial, admission diagnosis, I can look, remotely from my office here at the hospital records, and I can see kind of real time what's going on. If it looks like a situation where, wow, I'm not sure this patient really needs admission, and then I'll reach out to the emergency room physician and say, hey, I could see this patient tomorrow in my office. I'd be more than happy to, follow closely and make sure that this is a successful treatment and avoid an admission in that regard. So, but if it's obviously if someone's being admitted with a stroke and getting TPA, yeah, well, that's a required admission, then I'll follow that either remotely or give the hospitalist a call or something like that. So it all, I guess, is kind of dependent on what they're going in to the hospital for. And at least that's how I divide it up. But I do keep a relatively close eye on it. Like I said, it pops up on my desktop, and I just open it up and take a peek, and then I'll go into my hospital has Epic, so I'll take a peek through Epic and see what's going on, and go from there.
So just to kind of contextualize this further, Dr. Prostko, do you have any sort of a anonymized kind of real life anecdotal example of a situation where you saw an admit reason that indicated to you that this didn't need to be an inpatient admit that you were able to follow up on?
Yeah, okay, there have been several, like even an atrial fibrillation. Okay, if someone converts and they're not having chest pain, they're pretty good functional status. I could call several times. I've done this, talk to the emergency room physician and said, hey, the patient converted with a little bit of medicine. Why don't we put them on a little bit of anticoagulation, and we could follow that up as an outpatient. And even the cardiologist, if they see him in the ER, will often agree to that. Other types of things that we could discharge would be, in a high functional status patient, a little community acquired pneumonia that may or may not need admission. Patient's doing pretty well, oxygenation's good, there's no problem. And I'll often say, hey, call the ER doctor and say, hey, I don't mind seeing that patient. We could even give them shots of Recephin or whatever's needed, and try to avoid an admission in that regard. And many times the patient doesn't even want to be admitted. Other diagnoses that would go there would probably be, cellulitis that are kind of on the borderline, or diverticulitis. Some of those are sort of, well, should they be admitted? Shouldn't they be admitted? Well, we could kind of swing that pendulum to the non-admission side. And, of course, admission to hospital is always available. It's not like if we don't admit them this time, and oh my gosh, this isn't working, we really do need IV, vancomycin or something. It's not like we can't do that. So now, one thing that I'm quite pleased with is we are getting a 3-day waiver with our ACO starts July 1st in the enhanced program, and we will be having a 3-day nursing home waiver. So let's say someone does kind of fail, aggressive outpatient treatment after an emergency room visit or something, we can actually put them without hospitalization for several days into a nursing home rehab bed and give them IV Vanco or IV, antibiotics of some kind to try to help their case along. So that would be a new tool for us, which
that is fascinating stuff. I think we could have a whole separate webinar on the new 3-day waiver for nursing homes, and we just might, because I think that there's huge ramifications there. Dina, going back to some of the things that you said initially, I'm really interested in, Dr. Prostko certainly has, her own perspective as a physician, but from your perspective, you are, as you said, operating after the fact, and you said a lot of you put your notifications in the hands of the PCPs because they prefer to make their own phone calls, and that, a lot of what you provide is kind of at the elbow support to enable that, with training and call scripts and things of that nature. I'm wondering, what was the outreach like from your perspective when you were first kicking off this service? And what was it like? What was the conversation like when you went to these PCPs, your affiliated PCPs, pediatricians, what have you, and said, hey, I've got these, I'm going to be sending you these notifications. Here's what we want you to do. Here's what we think can, be the outcome. How did you message that to them? Were they all receptive? What was it that really kind of made the light bulb turn on for the providers to buy into the service?
I would definitely probably say they were not all perceptive. I think when you're talking to a physician, I think they understand it and they get it. But when you're talking to a front desk staff or even a care manager, it's showing them the value to the patient and why we're asking them to do it. And the biggest thing is obviously patient safety. It's not about the money. It's about good outcomes, and patients don't want to be in the hospital. They don't want to wait 6 hours in the emergency room. And I think back, a few years ago, medicine was definitely more reactive, and it's just making that switch to proactiveness for our staff and for them to understand why they're doing it and what really is the message. So, so they went to the ER. They don't want to come back here because they've already seen somebody and they feel better. So it's giving them the tools to kind of, in the scripting, to kind of overcome some of the pushback from the patients. I think nowadays patients have had this conversation multiple times with multiple providers, and it is an easier conversation. And just understanding what they can do if somebody is discharged to home health. What do they need to do and to set the target timelines that this patient needs to be called within X number of days, and this is the action. If they were admitted to a SNF, they're asking, what am I going to do with that? They're already in the SNF. Well, there's a lot of things that we need to do if they're admitted into the SNF. And specifically, the biggest value that you can give as the primary care provider is to kind of set the expectations of the specialist or the long-term care facility or even the home health nurse of what to expect from your patients. Specifically around ADLs, they don't know how the patient normally is. So if you can set those expectations, you can reduce the length of stay or the length of nurse visits that they've been discharged with. So it's just educating the patient, really it's usually the front desk staff or the nurse that's calling to check on the patient and just showing the patient, hey, we care, we want to keep you healthy, we want to keep you safe.
That's excellent. What do you have, what is your interaction with namely that front desk staff, but the practices as a whole? What's your interaction on an ongoing basis? Like, do you, Dr. Prostko alluded to their app having, kind of indications on utilization of the app. Is there any way that do you reach out to the physicians on an ongoing, recurring basis to ensure that they're still using those files you send them every morning? Do you have any sort of a metric to track who, how many folks they're following up with and who's really championing utilization of these reports, and can you put them together with the folks that may be a little more reluctant, or do you do anything like that to track kind of utilization?
Yeah, so I wholeheartedly agree there. If you don't hold them accountable, a lot of times you don't actually get the action. And I think it's important to note that you're probably going to have to retrain. It's not train once and everybody knows what they're doing. It's a constant reinforcement of the message. With staff turnover, maybe they didn't get the whole message. So it is a retraining efforts as well. And if they have a care manager, getting them involved, somebody who's already following the patient, whether it's from your ACO or from the primary care office directly. If you have care managers, and I think a lot of us do now, notifying them and the office is ideal, and then them creating a plan for the patient. But they need to be held accountable, and you need to have the conversation, whether it's monthly or quarterly, whether you have an app that is identifying if they're doing it, or you're just having a one-on-one conversation with the person, and how you can assist them and what kind of obstacles they're seeing, and if we can help them overcome them.
Excellent, excellent. So, kind of to distill, we're running out of time fast. There's been so much good information. I want to kind of tie up a few loose ends before we jump to Q&A. You've alluded to, both of you have alluded to a lot of great ways that you're leveraging the service. And I would encourage the folks on the phone, if you go to the Florida HIE website or you email us after the fact, we can point you in the right direction. But there's a resources page on our website that has some really in-depth case studies from both primary partners and Palm Beach ACOs. They've both pointed to some cost saving statistics, but they boiled it down even to readmit reduction and avoidance, and what they've been able to do is really, frankly, astounding. Even from my point of view, dealing with a lot of folks who use this service, we've really, truly got two of the best right here. What would you all say is kind of the most impactful thing you are doing as an organization at the ACO level or the practice level to reduce avoidable readmits? Just what is I don't want you to give away all your secrets, but what's the one thing that you believe to be truly most impactful that you do on a day-to-day basis to avoid readmits?
Okay, I could go ahead and speak first. I think some important things are having an Opendoor policy, making sure that the patients know that certainly during office hours they can even walk into the office and they'll be seen. And then, in the event they can't get you on the phone or whatever, that's always an important thing. The other thing would be driving patients towards an urgent care facility for after-hours care that you have a relationship with, and that is not a freestanding emergency room. Those are important things. So if you have a relationship with a good urgent care center that gives you your records, and you know the patient was in there, and you're able to follow up closely, that's a big deal. And so isn't going to just start referring to every other specialist on earth, and you get the patient after 15 more referrals to another specialist a month later. That's the thing that you want to try to avoid. So closer contact with the patients, closed loop scheduling, making sure every patient leaves with an appointment, making sure every patient knows that they can come in anytime during office hours and be seen, and then trying to communicate clearly. And this is an ongoing thing too, because patients, need ongoing reminders of this. It isn't, I wish that weren't so and you could just say it once, but it's just not true. Then having a relationship within a freestanding urgent care.
Excellent. Yeah, I think you touched on the urgent care versus ERs freestanding or otherwise. That too could be an entirely separate webinar that we could cover. There's a lot that goes in, a lot of thought behind that as well. Dina, what would your response be to that same question?
And I think we are in total agreement with Dr. Prostko on that. The open door access is key, and the education for your patient is where you really see things turn around. If your patient's not engaged, or they're not knowledgeable that you have an open door policy, or they're not knowledgeable they can call you after hours, then you're not going to get the results that you're anticipating. So often they have life events that come up, and they come up swiftly, and they go to the ER because maybe they need to go to the ER. We're not talking about the people that've got a hangnail situation. Those are a different cohort of patients, I'd like to say. But so you're talking about the patients that truly had a life event, truly had an inpatient that needed to be there, and they're confused when they leave. They've been there for 5 or 6 days. They're waiting all day for the discharge nurse to come let them go, and they're being discharged with specialists or home health. They're not sure. They're just following instructions. They're following the directions, and maybe they misunderstood the directions. The biggest impact that we need to have on the readmissions is to do the TCM visits, get them back into your office regardless of what the discharge instructions say. Educate them, show them that you care, show them that you want them to be healthy. They don't want to go back to the hospital as much as you don't want to see them back in the hospital. So I would say probably the TCM and just re-educating them. Hey, we're here for you. We have an open door policy. You can call me after hours. Is I think most important.
It is, kind of, it's refreshing. It's good perspective that if you think about, we've got this, very technically, this technically sophisticated service that we've rolled out statewide, to handle all of this data and make these determinations and use these business rules in real time, and get it out to all these subscribers such as yourselves. But at the end of the day, it's powering person-to-person interaction. It's facilitating the relationships, which are really and truly, I think you've both alluded to that throughout the webinar, that it is really, at the end of the day, it's the PCP to patient or the specialist to patient relationship that is what's going to affect the most change. And we are just providing as much ammunition as possible, so to speak, to strengthen that relationship. But it is, I don't need to tell the two of you, or surely anybody else on the phone, that it is still, it is a relationship, an ongoing relationship that needs to be, maintained. So this is all fantastic stuff. Before we jump into any questions, I just, one other thing worth covering, if for only for my edification, so I know, what we can be doing better. What's the one thing that you would like to see from the encounter notification service that we're not doing today, that would better facilitate, care coordination for readmission avoidance?
I'm not sure I have anything specific. Just keeping up with this, getting more and more patients enrolled in it. I don't know how the patients are collected or whatever, whether that's claims data or whatever, and how they get assigned to the individual provider. but of course, trying to tighten that up would always be a wonderful thing, so that you're at 99% for your patients and notifications. But I really truly don't have a notion of how that's accomplished.
Just to dive into that for a second, are you kind of referring to the match rate? So getting more notifications for your patients, to be more comprehensive as to their utilization?
Right. So, like, let's say if I have a new Medicare patient, and 2 months or 3 months into it, they go to the ER, well, I may or may not get notified on that one. So I don't know how that patient then gets added to a notification list for me, or how that would work. But of course, trying to cinch that up is always helpful.
Yeah, there's two things I want to touch on real quickly right there. And number one is that whether you're an ACO, a physician practice, a health plan, any of the types of organizations who can subscribe to receive notifications, generally operationally speaking, we work with our subscribers to kind of get a new set of the patients they want to subscribe to on a monthly basis. But as you know, we have 100 subscribers, so that's a lot of bandwidth just refreshing those 100 patient panels every month. One thing we're doing, as you're all aware, you get new patients more frequently than once a month. You can get new patients on a Tuesday and not submit a new panel until a week and a half down the road, or whatever the case may be. So that's one thing we're working on from a technical standpoint, is developing processes to where subscribers can upload new panels on a more frequent basis. So that's more of a self-driven, self-service, automated process, and subscribers can upload a panel once a week if they want to, or conceivably down the road even once a day. That's what we're trying to get to, so that folks can really just add new people to their panel as needed. So that's one thing we're driving towards. Another thing, Dr. Prostko, is kind of a blind spot in terms of getting to that 99.99% match rate. What we really want to get to in terms of matching notifications to your patients. One thing we have a lot of trouble with is observation status, because emergency department patients are very clearly labeled in the messages we receive, and inpatients are as well. But it's that observation status is very nebulous. It doesn't have the standards around it in terms of data identification that those other patient classes do. And so observation status, one hospital can label it one way, and then another hospital can label it differently. So there's, so observation status, if it's coming through in a way that's not indicated to us, we don't know to label it as such. And so that's another thing we're working on improving, is ascertaining what that logic is on a source by source basis, so that we can properly identify and label and then notify you on observation status patients. So those are two big things we're working on that I think would get to exactly what you articulated. Dina, what would your response be with regards to the one thing that the Florida HIE could improve upon ENS to better facilitate your processes?
Well, you took mine, Evan.
No, I'm sorry. I thought you might have a few.
No, actually, yeah, that was going to be the one thing that I wrote down, was the ability to have the health systems share the observation admission alerts, because I think that there is a big black hole there. So I know you guys have come a long way since we've started. I would think, and maybe it already exists, but I would think that the kind of next level that I know we want to get to is to kind of go beyond the PCP's office, go beyond just what we're doing. How can we share this information back to either the specialist, or even the care manager, or even the behavioral health counselor that's seeing this patient? So I'm kind of leaning toward maybe we could create a custom field in our panel that kind of helps us route those patients that are being followed beyond the PCP. I know we're kind of engaging a social worker for some of our chronic disease populations that is going to be interested to know if this person was just in the emergency room. And surely we can build that technology on our end. It's just another step.
Agreed.
Do you have any groups that are doing something similar?
Yeah, so that, you know, this is this overarching point of provider routing, so to speak, which is as Dina articulated, it's really automating the flow of notifications past the original recipient to the other downstream providers, whether that be a specialist or a behavioral health counselor, things of that nature. And there are we do that in a lot of ways, and we're actively working on expanding the ways by which we can do that. Dina alluded to this thing called custom field, and what that is just any other piece of information that you want to associate with a patient when you're putting it in your panel and sending it to the HIE and saying these are the people I want to subscribe to. Those custom fields can be identifiers associated with the PCP, or they can be something like a behavioral health counselor. And if you can identify other downstream members of a of the patient's care team, there are certain ways today that we can use those identifiers to then fire a copy of the notification out specifically to that care team member as well. If you put a if you put a PCP, if your affiliated providers have direct messaging, for example, through your EMR, and if you put each provider, the affiliated PCP's direct address in one of those custom fields, we can fire off a copy of the notification to that direct inbox, as well as a centralized endpoint for all of the notifications that we're sending you as an organization. We have a prompt user interface that is a very lightweight care coordination tool that some organizations opt to get their notifications through, and we're working on doing the same thing with that prompt interface, such that if you have 5,000 people on your panel and 1,000 are attributed with Dr. Smith and 1,000 are attributed to Dr. Brown, if you put Dr. Smith in a custom field for all of them, you put Dr. Brown in a custom field for the next 1,000, we're working on being able to credential Dr. Smith and Dr. Brown their own prompt accounts, wherein they would only see the 1,000 attributed patients in the larger ACO panel. They would only see the ones that they have access to, that they have authorization for. And that would allow each individual practice, whether it be a scheduler or front office staff, case manager, can log in and only see their practice's notifications without necessarily being reliant on somebody to flow that downstream, so save some administration work on combining all those reports and then sending them back out to all the practices. We're working on automating that. So there's a few ways we can do it now today, depending on the technical capabilities of the PCP and what information you have on file for them that you can put in a panel. And we're working to simplify that even further because we know just how important that is. And with that, I think we've got about 10 minutes left. Pam, are there any questions to field or anything at this time?
Right now we do have one question. So just a reminder, if you do have a question, you can go to the webinar toolbar. You can either raise your hand or you can type your question in the question section. The question that we have currently is, do you see a place for inpatient, outpatient mental health and or substance abuse facilities in an ACO?
Dina, Dr. Prostko, what are your thoughts on?
That's a tough situation. As you know, there's the behavioral health code that's similar to the chronic care management code now, and I don't know how that really so far hasn't really been adopted by our doctors the same way chronic care management has. I think people are beginning to see the use of chronic care management and create programs around that. Behavioral health, not so much that I've seen. I believe there's very few codes like that that I've seen come through the claims data. But You mean having them be members of the ACO? I don't understand how that would mean. You know, of course, we're using those facilities for beneficiaries, but I don't know how. What do you mean, like how close a relationship?
Let me care coordination in the same sense as what Heather has said. Heather, I am going to try to unmute. Heather, I've just unmuted you. So maybe you can articulate your question or help us with your question.
Yes, ma'am. Are you able to hear me?
Yes, we are.
Okay, perfect. So from what I was thinking is just when I belonged to an ACO in the past, I actually interned for Primary Partners a very long time ago. It was very new with care coordination for chronic care management. And I'm just thinking of a way that we could do that for mental health and substance abuse the same way that we are doing that for chronic care management.
Well, I think Medicare has created the behavioral health codes. And I mean, they do have some fairly stringent requirements. And yes, I do believe that that should be something, because some of the most expensive patients, as you know, are the bipolars and substance abuse patients. But I just haven't seen a concerted effort right this moment to begin using and, you know, embracing those behavioral codes or programs. Now, there are a lot of people that are beginning to do chronic care management and create entire programs in their office around chronic care management. And I guess some of those folks could be, you know, enveloped in that sort of program. And I would envision in the future in practices that have a number of those patients, that those behavioral codes will also, you know, become part of a program inside of an office practice. But like I said, I haven't, you know, I do get access to the claims data for all of our physicians because I'm a medical associate advisor. And so I go out and visit offices. And I haven't seen to the same degree the behavioral codes embraced the same way chronic care management. But chronic care management really has taken years for people to get used to the notion of it. Now they're using it and they're saying, okay, well, I need to get it all my 70, you know, under 75 ladies in for a mammogram. So they're using it, you know, to kind of manage some of those quality measures and that, and also, of course, getting, you know, calling our most expensive patient list, our frequent ER frequent flyer list. I mean, we of course run all those different patient lists, but at this juncture, I have not seen that embraced in the same manner. That's not to say it won't be, because I think it probably will be, but not quite yet.
Okay.
I hope that helps.
So
I don't know.
Yes, ma'am.
Yeah.
Thank you.
Hi, Heather. This is Dina.
Hi.
I just wanted to let you know, I don't know that they need to be members of the ACO, but I definitely think they need to be part of the care team. And I would agree with Dr. Prostko. It's not widely used, but it doesn't mean it shouldn't be. And it may take years to do so, but I think that it's going to take trust from the patient side, that they can trust their PCP to have that conversation. And that goes back to the PCP to patient relationship. It has to be strong so that they'll trust what that they can tell their PCP, hey, I'm struggling with this and I need some help. We do have companies that we refer patients to, but they're definitely not part of our ACO provider mock-up.
Okay.
Evan, did you want to add anything?
No. I mean, I can go one step further, you know, one step further into the past than chronic care management. I mean, it was before that, it was transitional care management, and that took a couple of years. It seems as though, you know, these are very large changes to affect on a practice level in terms of how they interact with patients, and it's the next one's always going to take a couple years. So it seems like a
Right.
logical progression to go from TCM to CCM and then finally to behavioral health. So I think that's something that we should all collectively monitor as folks really get to a place of comfort with chronic care management, and we look to see what's next.
Okay, Heather, I'm going to put you back on mute. And see if we have anybody else that has a question. We do have somebody that is interested. They are the CEO of a community mental health agency and wants to know how to move forward with using this type of initiative. And just for anyone else that's interested in participating in the Florida HIE, in particular the Encounter Notification Service, on your screen right now is our contact information. There's my phone number, but more importantly, there are 2 email addresses. If you will email either one of those email addresses, you will reach someone at the first email is flhii@ahca.myflorida.com. And that is contact out to the Agency for Healthcare Administration. And then the other is FLHIE_info@AINQ.com. And you can email either of those email addresses, and the last one goes directly to the help desk at Audacious Inquiry, the vendor for this service, and either one of us can provide information on how to get started in utilizing this type of service.
And if I could just add also, Pam, real quick, I also encourage folks to leverage those email addresses to reach out to us if they have, this webinar is really the first foray into what I hope is an ongoing conversation around best practices for readmit reduction and for better outcomes and cost savings, and really kind of leverage our champions. We've got a lot, Dina, Dr. Prostko have been fantastic. We've got a wealth of other folks that are leveraging the service who've done really amazing things. And I think that I want to, really, I know we all want to really start bringing people together to really share. It's one thing to just get the notifications out to the subscriber, but what happens after that has historically been a bit of a black box, so to speak. So if you have any ideas as to how we can further this conversation, whether it's via other webinars with different topics or other types of venues or things we could convene, please let us know how we can better convene this group to get everybody optimizing their involvement with the service to the fullest extent possible.
Great point, Evan. So if you have any ideas or have information you'd like to receive on a certain topic related to the HIE services, please email us and let us know that so we can provide you more information. Okay. With that, we are right at 11 o'clock, and so perfect time for us to end our webinar. Again, if you have questions, you can email us at either of those email addresses, or you can give me a call. I will tell you that I'm not in my office most of the time, so it's easier to get me by email. So reach out by email, and we will get back with you. Thanks again for participating in today's webinar. Thank you so much to our panelists, Dr. Prostko and Dina Lewis and Evan Carter for moderating today's session. We look forward to joining us next time. Have a great day.
Thank you.
Thanks a lot.
Do we hang up, Evan?
Yes, I believe so.
Okay. Thanks, guys.